diverse aspects of cancer care, ranging from cutting-edge diagnostic research to latest advancements in treatment modalities. This year, we had record-breaking 307 abstract submissions, and like every year, we'll be announcing various awards, including Hassan Rashid Gold Medal and Begum Mir Awards for Best Abstract Presentations, Bashir Alawi Award for Best Cancer Research published from Pakistan in year 2022, and few other awards in free posters, e-poster, free paper, and video presentation categories. The symposium is accredited by American Association of Continual Medical Education for 37 hours, and you can claim these by filling in the feedback form. At the end, I'd like to express my heartfelt gratitude to our organizing committee, scientific committee, our IT team, who have worked tirelessly to make this virtual event possible, our liaison office, our facilities department led by Farooq Aziz Saab, Symposium Secretariat, Ms. Anika, Shandana, and Marukh, my co-chair, Dr. Usman Ahmed, and colleague, Dr. Irfanul Islam. Now, without further ado, I would like to hand over the stage to Dr. Asim Yusuf, who doesn't need any introduction. He's Chief Medical Officer of Shaukat Khanum Trust. He has worked in this institution since its inception and has pulled it through thick and thin. Over to you, Dr. Asim. He's currently abroad on an official assignment, so he's joining us virtually.
Assalamualaikum. Kashif, could you confirm that you can hear me and see my slides?
Yes.
Great. Thank you. Thank you, Kashif, for that introduction. Assalamualaikum, everyone in Peshawar, and also all those joining us virtually for our 22nd Shaukat Khanum Cancer Symposium, which is being held in Peshawar this year. So I'm not going to belabor this. I think many of you will have seen our mission statement previously. Just going to point out the key elements as regards the symposium this year, our role in education of healthcare professionals and the public, and to perform research into the causes and treatment of cancer. And that is, those are the guiding principles on which this symposium was established and on which it continues to be run each year. So the Shaukat Khanum Cancer Symposium was first held in 1993. That was a year before the hospital opened in Lahore. And we like to think that somewhat uniquely, our symposium is funded entirely by the institution. There is no pharmacological support from the pharmaceutical industry, which we like to think allows us to be completely independent and to present only what we consider to be the best scientific research without any bias. As of last year, we've been running this as a hybrid event, which has greatly enhanced the educational content and allowed a wider variety of speakers to join us from across the world, as well as attendees who have attended from various countries and continents. Each year that the symposium has been held, bar 2003, when we held the symposium in Dubai, each year other than that, the symposium has been held in Lahore. Initially, it was a biannual event, but for the last several years, it's been run annually. So why at Peshawar? So our hospital in Peshawar opened in December 2015, coming up to 8 years of clinical functions there now. It is a full-service tertiary care cancer hospital with all diagnostic and treatment facilities for cancer under one roof. It serves all of Khyber Pakhtunkhwa, as well as northern Punjab, and incidentally much of Afghanistan. As you will know, a number of our patients have and continue to come from Afghanistan for treatment. The hospital in Peshawar was JCI accredited in July 2019. And as part of the Shaukat Khanum healthcare system, our entire system achieved enterprise accreditation in August 2022, just over a year ago. And we were at that time only the second institution in the world to obtain this accreditation. Earlier this year, we were accredited in Peshawar as a training site by the American Society of Healthcare Pharmacists. And again, we're one of only a handful of institutions outside the United States to have that accreditation and training opportunities. And finally, just hot off the press really, in September this year, we obtained the coveted COPI certification from the American Society of Clinical Oncology, which is an oncology-specific certification. And again, this was obtained jointly by Shaukat Khanum Lahore and Shaukat Khanum Peshawar. So turning to our role in education, the physician education programs that we currently have at Shaukat Khanum Peshawar include the fact that we are a CPSP accredited training site in internal medicine and radiation oncology. And literally hot off the press, we've just received official acknowledgement of this today. We are now recognized in palliative medicine and surgical oncology as a training site by the CPSP. So palliative medicine and surgical oncology are both post FCPS, second FCPS training programs. We also run a number of post-FCPS hospital fellowships in colorectal surgery, in hepatobiliary surgery, and in upper GI surgery. Education extends to our colleagues in the allied health professionals as well, and we run postgraduate diplomas in medical laboratory technology and a diploma in respiratory therapy at our institution in Peshawar. Turning to research now and our role into the research into the causes and treatment of cancer. We are fully staffed with clinical research staff, basic scientists, biostatisticians and cancer epidemiologists, research nurses and pharmacists, and obviously qualified and experienced physician investigators. All research is carried out to the highest scientific and ethical standards with an institutional review board to ensure that the rights of the patient are protected. And we believe in a collaborative approach to all the research that we do. We have a number of collaborations with institutions within Pakistan as well as overseas. And so far, we've published almost 1,200 peer-reviewed indexed publications since the inception of the hospital in Lahore, and Peshawar continues to contribute to that. We have 19 basic science research projects underway, 8 ongoing clinical trials, and 4 full-time PhDs employed in our basic science sections. I'm preaching to the converted here. I don't really need to tell this audience about the role of BRCA1 and 2 in breast cancer. But in Pakistan, BRCA1 and 2 mutations have been found to account for 23.4% of cases in families with breast or ovarian cancer. And much of this is derived from our own basic science research effort led by Dr. Usman Rashid and colleagues. We launched clinical BRCA genetic testing in Pakistan in March 2020. The first 1,000 cases were performed by the Basic Sciences Department, and when the systems had been fine-tuned and protocols were had been verified, this has now been handed over to the Pathology Department. This allows for faster, more efficient testing. Reporting is available within a week and allows for informed decisions to prevent or detect hereditary breast and or ovarian cancer at an earlier and thus potentially treatable stage. It also provides vital information for biological relatives of individuals with the mutation. Turning to next generation sequencing, which is also something we've started relatively recently at Shaukat Khanum. We have the NGS system, which can identify the 50 most common genes associated with cancer, and this is up and running. Within the next few months, we hope also to launch NGS for genes associated with hematologic malignancies. These are the common genetic mutations we are currently able to test. And moving ahead with the research, we launched a Journal of Cancer and Allied Specialties under the umbrella of Shaukat Khanum some years ago. This was really a labor of love contributed to by a number of individuals across the years. And we're very proud to be able to tell you that as of August this year, we have now achieved listing on PubMed. And so this is a fully integrated indexed medical journal and one of only a handful of journals from Pakistan which are indexed on PubMed. So that's a great achievement for all those who led this effort. Time will not permit me to name everyone involved, but Dr. Arif Jamshed was one of the early pioneers of this effort. Dr. Humayun Bashir, who I know is attending virtually today, continued this, and Dr. Khwaja Shahryar Nasir, who is the current editor, really led the effort, particularly to get this indexed on PubMed. So I'd like to thank all of them. We also have a significant role in cancer registration within the country. In 2005, we established the Punjab Cancer Registry, which now collects data from 21 districts in the Punjab and is the largest population-based registry in the country. It has 27 collaborating centers, for both within the public sector as well as the private sector. We have a data collection app, but paper-based forms are also distributed. And we provide monetary incentives to those who help us collect data from the government institutions. The registry has managed to have a number of publications over the years in index journals, including the BMJ, some of which are listed here. And this is a map showing the current coverage of the province of the Punjab. In 2015, we launched a sister registry, the Northwest Cancer Registry, which covers Khyber Pakhtunkhwa, Gilgit-Baltistan, and unoccupied or Azad Jammu and Kashmir. And this also published a couple of years ago now the cancer incidence in Khyber Pakhtunkhwa in Pakistan. I believe this was also in the BMJ. This is the sort of data collection that we have from the Northwest Cancer Registry. Obviously, this is not complete. It takes a number of years to achieve completion or near completion, but we're well on the way, and we look forward to your support and to many of you in the audience joining us in this collaborative effort for the greater public good. So it remains only now for me to thank the organizing committee. Anika Agha and her colleagues in HR have already been mentioned. Mr. Nasir Salim, many of you will know, organizes all our travel arrangements, and you will have had personal contact with him. Dr. Arif Jamshed is, I know, in the audience in Peshawar today, and although we don't have any such official title, I like to think of him as the emeritus chairman of the symposium. He really took the symposium from a very small meeting to a very large national meeting, and what became Pakistan's national cancer meeting over a number of years. So I'd like to thank him for all his hard work and contributions. Dr. Kashif Sajjad, who preceded me as the symposium chair and has done a great job. He's also the medical director at the Peshawar Hospital. His co-chair, Dr. Usman Ahmed, who's head of medical oncology in Lahore and will be the chair for the next year's symposium, inshallah. All of you for attending, obviously, but whether it's virtually or in person. And we look forward to seeing you all in Lahore next year for the symposium, the 23rd symposium. And you can make a note of the dates. This will be from the 1st of November to Sunday, the 3rd of November, inshallah. So in closing, I'd like to thank you once again, and I hope you enjoy the rest of the meeting. Thank you.
Thank you, Dr. Asim. Thank you, Dr. Asim, for this. Now I'd like to introduce our plenary speaker, Professor Syed Hussain. He completed his doctorate in oncology from Birmingham. He's currently professor and honorary consultant in medical oncology at University of Sheffield. His areas of interest includes Uro-onc, clinical trials, and early drug development. He's published over 125 publications in peer-reviewed journals, 4 chapters in textbooks of oncology, and has secured over 15 million grant for the studies. He's going to tell us about precision medicine and oncology, changing landscape in cancer management. Over to you, Professor Hussain. Thank you.
Assalamu alaikum. Thank you very much for the generous introduction. I have to say it has been a real privilege and a pleasure for me to be at Shaukat Khanum delivering this plenary lecture. And great to see you all. I think what I will try to do is to set the stage where what Shaukat Khanum is already delivering has been phenomenal, and what we can further do working together in collaboration, where there are huge opportunities where Shaukat Khanum can hopefully generate more of these sort of publications, which Dr. Asim has just talked about, and more high impact reviews and publications that can come out from here. So without any further delays, these are my disclosures. In terms of the learning objectives, the way we'll try to do, we'll look at the challenging increasing cancer burden. And I think we have to think about, when we talk about cancer burden and treatments, we have to look at disparities in treatments as well, not just between sort of third world countries or countries with less per capita income compared to Western civil nations, but within UK, for example. When I talk about UK, there are disparities in treatments that are available within UK patient populations and things like that as well. And I think those are sort of things that we need to talk about and think about, where there are huge challenges in this environment in Pakistan, how many huge opportunities that it throws as well, where things can come out from here. We will talk about challenges with drug development and the cost of drug development, and how actually Shaukat Khanum and institutes from Pakistan can play a key role in trying to develop these things further. We'll talk about some of the discussions around translational studies that have significantly changed the paradigm of cancer management, where patients are living with cancer, and they are still in the palliative mode, but still patients we're seeing years and years down the line with advanced cancers living with metastatic cancer, which is not growing any further because of biomarker-driven treatments. And then we'll talk about the increasing ctDNA use in clinical trials as well, and the huge opportunities that it throws in for future studies as well. So if you look at the cost of drug development, there's a huge cost of drug development in that sense. If you look at the number of drugs that are coming through, starting from 10,000 compounds, going to 1,000 to 10, it takes a number of years, and it takes a huge amount of cost as well. And when I talk to my colleagues in the global industries as well, they're always keen on more patients coming into clinical trials. And that's where I feel like where the data that is available in Shaukat Khanum and the way the cancer registry is maintained, we have opportunities to deliver in those trials as well. In terms of the early drug development, what are we trying to do? We are trying to accelerate the anti-cancer drug development. And that is the key, where you have a biomarker-driven, well-designed, and expertly conducted trials, which are adaptive clinical trial designs. So you basically can change the design and make it much more quicker to get to the results, get to the endpoints, design your endpoints accordingly, and question and answer of robust scientific hypothesis that utilizes rationally designed and molecularly targeted drugs. Previous paradigm has been, where will the drug work? And the phase 2 trial program, and then moving into phase 3 trials. What is the new paradigm? We are looking at the biological basis of the cancer. We're looking at patient population. We are identifying target and the drug, and then hypothesis testing trials using biomarkers. And then this is looking at basically the updated compared to the original design was a drug candidate, pharmacokinetics, pharmacodynamics, then achievement of the biological effects, and then clinical response by looking at large clinical trials. Now we can look at population identification first. So you're not treating all 100 patients with the same drug, but you're identifying the 20 patients who are more likely to be getting the best response. And there have been a lot of examples where a drug could have been actually thought of not having any impact on cancer. And I can remember Iressa, which we used to call ZD1839 in the late 90s, early 2000s, and how it looked like a negative trial in lung cancer, but in a subgroup of patient population, it had a big impact. So I think those are things have moved on to, where we look at targeted drug candidate, then validated predictive assays, then using pharmacokinetics and pharmacodynamics, and then biochemical pathway modulation, achievement of those biological effects, then hypothesis testing using intermediate endpoints. So also, because patient is a huge resource and we have to think about them, how we can get those treatments earlier to them. Similarly, treatments that are not likely to work, how we try and move that away from our patients as well. So this is a two-way street, where there are some drugs that we can move to patients quicker. Similarly, there are some drugs which may just cause toxicity without any significant benefit. So I think these are the challenges, but within those challenges, there are huge opportunities here. And then we reassess molecular alterations. So what we thought was in the baseline, how things are when we are treating patients with these drugs, and then inhibition of the resistant biological pathways. So again, these are different mechanisms, these are different pathways, but they all work if we have designed our trials very well. And this is now increasingly feasible with the advent of these small molecule drugs, which are targeted therapies. We're starting to see early responses and long-term responses as well. So these are some patients with melanoma and advanced cancers where they have had these treatments with BRAF, for example, small molecular inhibitors, which has led to significant response within few weeks of treatment. And those are the sort of things that are really driving cancer medicine forward. So looking at the BRAF V600E mutation in melanoma and seeing a radiological response of 81%. And more of that is important because you're looking at the cancer statistics. The number of cancer cases will continue to grow, and the mortality figures will continue to grow as well. So this is looking at 2008 versus 2030 and looking at the predicted. So these are the colorectal GI cancers incidence and GI cancers mortality. But if you look at 2008 compared to what it is likely to be 2030, both incidence and mortality are going to increase for GI cancers, for breast cancers, for prostate and lung. And this is important to say that this cancer burden is not coming down. This cancer burden is going to further increase in years to come. And it is very important for us, wherever we live, whether we are in Pakistan or we are in UK or in North America, it is important that we think about these figures. We think about the cost of treatments as well, and we think about how we can deliver the best treatment without much disparity in different parts of the world and different parts of the countries as well. And that is where I think it's a key strategy where really places which are so well organized like Shaukat Khanum can make a big difference. We know that cancers are detected at later stages. So early diagnosis, for example, in all cancers, the 5-year cancer-specific survival is 89%. But 5-year cancer-specific survival, when diagnosed late, is 21%. For lung cancer, it is 5% with distant metastasis and 56% 5-year cancer-specific survival when it is detected early. And the reason to talk and discuss that is because that gives us the opportunity to think about prevention, because prevention can be much cheaper in the long run for a country, but again, it requires long-term plannings and things. And this is really key to think about, where Pakistan and places like Shaukat Khanum with good cancer registries can make a big difference, looking at 5 years and doing some screening investigations in certain cancers and seeing what the impact of that will be in outcomes. But the outcome will be measured not in 1 or 2 years, it may be measured in 5 years or 10 years or further down the line. So it requires long-term policies and long-term healthcare decisions. A window of opportunity arises for earlier intervention when you start to look at how the tumor initiates, and when it starts to turn to pre-malignant stages, then expansion of malignant clones. So the driver of those malignant clones, the driver of those drug resistance could be different. And that is why sometimes with even a small number of patients, you can do some really exciting and fascinating studies where you look at the metastatic disease, take a biopsy of that and see whether what the primary diagnosis was being driven by which pathways, and where the advanced cancers and the multiple metastatic sites, are they being driven by different mechanisms and different driver mutations as well. And that's where genomic aberrations acquired early during tumor initiation shape future different disease trajectories. And that is quite important because with late dissemination, that is where we're seeing they become more like disease-specific mortality and all that. And that's what, if you're trying to get them early, understand the driver mutations better, you can make a big difference. And liquid biopsies and circulating tumor DNA concepts comes here, where you can do a patient selection, looking at enrichment strategy for clinical trials. You're not treating every patient in the same way. You're considering some patients who may actually not need additional chemotherapy treatment based on these tests. And I'm pleased to say that some of them are now entering into randomized clinical trial stages. So these are sort of key things. Early dynamics of the ctDNA as a biomarker of response, monitoring the emergence of resistance mutations, and detection of the minimal residual disease after curative therapies. So you are using your techniques and technologies in the right way for the right group of patients. Things to keep in mind regarding circulating tumor DNA in clinical practice: successful detection of a mutation in plasma. It will look at cell-free DNA as well as, so you need to see that what is the amount of plasma of cell-free DNA and fraction of the circulating free DNA that is made up of ctDNA. So there may be some heterogeneity that you will have to account for when you're looking at these trials. Clinical characteristics: type of tumor, tumor burden, prior treatments, whether they have been heavily pretreated, could things have changed, What is the timing of these samples as well are going to be quite key. Timing of collection, subclonal heterogeneity, sensitivity, specificity feature of the assay, and then looking at single mutation versus third generation sequencing, single nucleotide variants, epigenetic markers, tumor mutational burdens, mutational signatures. So you can see there are different factors which can influence the outcome, and it is important to counter for and to think about those before when you're designing your study, and then look at the concordance between the tumor and the circulating tumor DNA genotyping. Initial sample requirement, you can have a tumor tissue or blood sample. Again, blood sample is a simple one. You can EDT a tube, similarly tumor tissue, which is more invasive, but you will require then paraffin embedded or free tumor tissue, FFP tumor tissue will be required for that. In terms of the CTCs, it's protein expression, gene expression, DNA methylation. There are a lot of things you can look at: DNA abnormalities, miRNAs, epigenetic alterations, functional studies, single cell analysis. So in terms of the CTC, circulating tumor cells, similarly circulating tumor DNAs, and then ctDNA methylation, you can look at epigenetic signatures, circulating miRNAs, extracellular vesicles. Similarly, when you look at liquid biopsies, main technologies, you can have the CTC when you look at ctDNA, similarly with miRNA. So there are main technologies that will be required, which are mainly available in most parts of, when you look at Shaukat Khanum and the other places which have got these sort of technologies already available. The difference is when you look at the tumor tissue versus liquid biopsy. Tumor tissue will be standard for genotyping because you have got variants in the sample or highest possible allele fraction. Easier to determine if variants are tumor specific. Invasive procedure it is that can be painful. So you need biopsy for that. In terms of liquid biopsy, ctDNA, it's simple, fast, non-invasive test, which is with very easy sample access. And ctDNA can reveal a cancer's comprehensive genetic profile, potentially more accurate representation of tumor heterogeneity. It is able to perform multiple tests on the same subject, and you will have longitudinal samples. So basically looking at the baseline sample, then at the time of disease progression, then at response to treatment, then the disease progresses again. So multiple time points where you can look at, and non-tumor specific variants may be detected as well. In terms of residual disease, the problem is that where it's negative, patient may have already been cured. Or if it is still present, patient is perhaps not been cured. And that is where the sort of the key purpose is not to just treat every patient with anti-cancer drugs, but basically think about patients who do not need those anti-cancer treatments, spare the side effects, the toxicity, and the cost of those drugs unnecessarily to the patient as well. Prediction of relapse post sort of standard of care in the colorectal cancer, for example, ctDNA detection post-completion did show very clearly that there is actually benefit in those cases which were ctDNA positive. So these are quite interesting facts which we can utilize now, but working in a retrospective study to a prospective trial is the way forward. And the reason I'm saying it is that knowing the way things are available and present, there are a lot of these things that could actually be done and could be coming from institutes like Shaukat Khanum Cancer Center. This was a phase 3 IMvigor 010, which we contributed to and were part of. It's an international study, which was very clearly looking at atezolizumab versus observation in second line, in sort of the adjuvant setting in bladder cancer, which was high-risk muscle invasive urothelial cancer. So the trial showed, looking at disease recurrence, IMvigor 010 did not meet its primary endpoint of disease-free survival in ITT population, intention to treat population. But a pre-planned interim analysis was performed, but could not be formally tested. What was key was that within that study, a subgroup of patients had a ctDNA test done as well, which was recorded, and that was pre-specified ctDNA biomarker pre-analysis was performed using the Signetra assay. Evaluation of ctDNA in IMvigor 011 was done by tumor tissue and germline material, up to 16 mutations for personalized MPCR ctDNA assay. Then plasma samples were sequenced, and if greater than 2 mutations were detected, then sample was defined as ctDNA positive. Minimal residual disease samples were sent at time points before adjuvant treatment, cycle 1, day 1. And on treatment sample, cycle 3, day 1 was also assessed. If you look at the ctDNA biomarker evaluable patient population, the outcome is very similar. In ITT, hazard ratio of 0.89. In ctDNA, where biomarker evaluable patient population, this was 0.88. So baseline clinical features were very similar between the two subgroups where ctDNA test was done. What is interesting is that the ctDNA positivity actually predicted responses in these cases. So ctDNA positive patients in biomarker evaluable had improved disease-free survival and overall survival. So if you look at, these are the ctDNA negative and these are ctDNA positive, hazard ratio of 0.58 with a p-value of 0.0005. Similarly, if you look at basically overall survival, no difference in ctDNA negative, but in ctDNA positive, hazard ratio of 0.59. So this is a retrospective pre-specified analysis that was done, and that was part of the IMvigor 010, which was a negative trial, but the biomarker test was very interesting. And ctDNA clearance was quite useful when you look at cycle 1, day 1 patients who were ctDNA positive and had atezolizumab versus those basically who were ctDNA negative. You can see a big response in that, hazard ratio of 0.26. or disease-free survival and overall survival. So ctDNA clearance tells you whether this patient is going to do well. And the reason is that this will have implications for not just bladder cancer, where we tested this hypothesis. We are doing a phase 3 trial now on that, but further other different cancers, you can think about it and think about having some studies that may come out from Shaukat Khanum. So if you look at the overall survival as well, there's a significant difference in terms of the disease-free survival and overall survival. ctDNA positive with tumor mutational burden, high status, appear to have improved outcomes as well. So that was in a sort of a IMvigor 010 retrospective study from a large adjuvant trial that we looked at a subset of patients where ctDNA test was done and very clearly showed that there is role for these treatments in this sort of a setting to look out for that. And that is the basis for IMvigor 011 trial design, which is looking at exactly the same patient population, muscle-invasive, high-risk urothelial cancer, where we may offer them immunotherapy, adjuvant immunotherapy, but you're not going to give everyone adjuvant immunotherapy. You will look at for ctDNA. So they will have 6 weekly ctDNA blood test. They will have 12 weekly CT scan. As long as the CT scan is negative and ctDNA becomes positive at any point, the patient will be randomized 2:1 between atezolizumab versus placebo. So it's a placebo-controlled trial, which will look at atezo versus placebo. So quite a well-designed trial, and the aim is to see whether ctDNA can detect the patient who should have adjuvant treatment. Because the key thing is that we keep following these patients for 24 months. And those patients who are actually remain ctDNA negative and radiologically remains negative as well, very likely they do not need adjuvant treatment. Because at present, if you start giving adjuvant treatment, you're giving it to all the patients. Like in UK, nivolumab is available for PDL positive patient population, but we give it to everyone. While this study will actually save resources by not giving adjuvant immune checkpoint inhibitors for those who are ctDNA negative and scan negative if basically that trial comes out as positive. So ctDNA is incorporated as selective responsive biomarkers. Enrichment strategy is key, and exclusion of patients with no or minimal benefit. Early dynamics is a biomarker response to adapt treatment, and then monitoring of emergence of resistance and detection of the minimal residual disease is key. Sensitivity of assay is key so that there are no false negatives, and ongoing clinical trials in different scenarios will assess validity. And again, this was to say that there are oncology alliances that are coming up. And this is just to throw up for all of you to think about whether Shaukat Khanum will like to have some of these alliances nationally and internationally to develop being part of some of these big cancer centers and say what you can bring to them. And that will be a huge number of patients, because if you are part of these sort of alliances, you can be part of these. And that will mean that the collaborative research and publications that come out, Shaukat Khanum will have a say in those as well. So this is just to throw in that there are big opportunities across globally who will be really keen to benefit from the patient load that Shaukat Khanum has in coming into clinical trials. This was a study we did, and this was the first biomarker-driven trial in prostate cancer, which was TOPARP, which I was part of the trial management group with Johan de Bono and others. We helped design the study. It was looking at single-agent PARP inhibition who have anti-tumor activity in castration-resistant prostate cancer. Adaptive trial, designed biomarker-driven, but it was all patients coming into the study. What was interesting, we looked at BRCA1/2 ATM as the biomarker of response. And what came out from that was very interesting, that there were 49 patients when we were submitting it to New England Journal of Medicine, again, for the benefit of some of the junior faculty that are there as well. The paper initially was coming back to say that this is a small study. But what was the strength of the study? The strength of the study was the first study that was chosen that was looking at biomarker selected patients, 49 patients they were total, and there were responses in 16 patients. But of the 16 responses, you will see that basically in 16 patients had responses, and those patients who were DNA repair defect, 33 had no defect, 16 had. Out of those 16 with defects, 14 patients responded, while in those 33, only 2 patients responded. So all of a sudden, you can see that actually by enrichment of that, you are seeing a big impact on disease outcome. And that led to TOPARP A, B, and multiple trials since we have done in prostate cancer in different settings. And that led to improvement in the progression-free survival, doubling of progression-free survival. That translated into improvement in overall survival as well, 7.5 months to 14 months. So significant benefit by choosing the patients who are biomarker positive in that setting. So biomarker positive patients did much better with PARP inhibitor olaparib in our TOPARP study. There are different ways of doing things. You can look at the ex vivo determined cancer therapy, which is the work we are leading in Sheffield. And that looks at you take a patient sample in the real setting and then look through that patient-derived cell lines, patient-derived tumor cultures, and then you look at different drugs that can have an effect. And whether that will lead to improvement in outcomes, you can only test it in clinical trials, prove it in clinical trials before that becomes standard of care. So measuring drug action at the single cell level using a live biopsy. So you take the tumor tissue, take it, and then grow those cells, throw drugs into it, multi-culture, sort of in a multi-cell, you can choose different drugs to, and some of those drugs, like in UK, when we are trying to design trials, we try to use drugs which are already available. So these are standard of care treatments. What we want to do, whether this sort of a technology can help us to identify the right drug for the right patient. That is leading us more and more towards high precision cancer medicine, high throughput genomic and clinical outcomes in hard to test advanced cancers. Some of these trials you can do as basket studies. So cancers which have had multiple treatments already, you don't need to do it for bladder cancer, or colorectal cancer, or lung cancer. You can have a basket study which have all these cancers which have had multiple lines of treatments already, and you can use those sort of things in this setting. And the clinical validation can only be done within a clinical trial, where you look at the initial biopsy of the surgical samples, look through the MDT, and see whether these things will have an impact in the outcome. So it requires a large team, which we are doing it in Sheffield with multiple colleagues here. Things which have really transformed cancer care, like immune checkpoint inhibitors, which are improving response rates and survival in big ways, 7-8 month survival benefits we are seeing. More recently, we have seen the results from conjugate antibodies, which are extremely expensive and high-cost drugs in those settings. Even some of the data that was presented recently 2 weeks ago at ESMO, which looked at enfortumab vedotin plus pembrolizumab versus chemotherapy, showed significant improvement in progression-free survival with a hazard ratio of 0.45. And similarly, a big impact on overall survival with a hazard ratio of 0.47, with a 16 months versus 31.85 months survival. So doubling of median survival. I think the key question is here, how do we select these patients? Because if we treat all these patients with this drug, it's a very high cost drug combination. And I think that is where it throws huge opportunities for us to come towards window of opportunity studies. And that is something that doesn't require a huge amount of capital, but it requires a large number of patients. And that is something institutes like Shaukat Khanum can do. So window of opportunity studies provide opportunity to test hypotheses and generate data that may help in improving treatments forward. Primary endpoints must be very well defined. Multidisciplinary teamwork is key, and it needs close safety monitoring and patient selection. So INVEST is a trial which has been funded. We got funding from Roche, 1.5 million pounds, to do a single center study in Sheffield. Again, I needed pathology input in that. I needed urology input in that. So I'm working very closely here with Jim Cato, who takes the bladders out. In Sheffield, we do 120 cystectomies a year. Half of them are for non-muscle invasive, half for muscle invasive bladder cancers. And again, always look at what are the strengths in your center, where you have got the whole team around and available. You need somebody, a pathologist who buys into that. You need a urologist or a surgeon who buys into something. It doesn't need to be in bladder. It can be any disease setting where you feel you've got a big strength. But the main thing we are doing in Sheffield, for example, with me and Jim Cato as the CIs, patients who are planned for radical cystectomy, they will be having their bladders taken out. And in those cases, we will do the intratumoral. We will be basically giving intratumoral injection or intravesical instillation of weekly atezolizumab before the bladder comes out. So your standard of care treatment remains the same. That is taking the bladder out. The only thing different is that while they're waiting for surgery, we are not delaying their surgery as well. The surgery date is planned as soon as the patient sees my surgical colleague. And in between those 6 to 8 weeks while they're waiting, we're giving them weekly intravesical atezolizumab or intratumoral atezolizumab. The key thing is that, so it's a 3+3 trial design, looking at 2 installation routes, passive installation or direct injection into tumor bladder wall. So that is how we are leading this trial. 3+3 design to evaluate 2 doses, and 600 milligram we're starting with, going into 1200 milligram. We have already recruited 5 patients in this trial over the last few months. And there's a translational science component that has been funded as well. The key thing is that when we are giving the drug in the bladder, we are expecting very few systemic toxicities or no systemic toxicities. So far, we have treated 5 patients. We have not seen any single systemic toxicity. But the translational component, which has been funded as well, where about £1 million we got for that, looking at measuring bladder wall penetration of atezo by imaging mass spectrometry, correlate gene expression signatures and mutational profiles, quantifying changes in the tumor immune microenvironment, and defining the effect of intravesical and circulating tumor DNA. So these are all linked studies that are already part of this trial. Significant translational component is key here to learn. So any sort of window opportunity trials you wanted to start or you wanted to work on, I think it's key to have translational component, because that's what will help you. Plus the patient selection and the new drugs that are coming, most of that data is based on Caucasian patient population. And the data may be different for Asian, Middle Eastern patient population or other cohorts. And I think it's important that in Pakistan, in Middle East and other parts of the world, people look at our own patient population to see what is driving response and what is driving resistance. Because our response rates, our toxicities may be different compared to some of the other patient populations. On a similar grounds, we got funding to look at in FGFR positive patient population in muscle invasive bladder cancer. We got a funding with NeoWin, which I'm a joint chief investigator with myself, Guillermo Velasco from Barcelona, Andrea Necchi from Italy, and Johan Lariat from Paris. So 4 of us are together looking at biomarker positive patient population, 90 patients in total. And we were looking at half of them will have erdafitinib and half of them will have erdafitinib plus immune checkpoint inhibitor sertralimab. The key question we are answering is that, will that group do better by having that drug? These are again patients who are having cystectomy, but also we'll look at whether FGF leads to immune desert signature, and that is why IO will not work, or will adding IO in that group as well will give some additional benefit. Precision medicine is now a reality. Looking at different tumor groups, for example, in bladder cancer, in neoadjuvant setting, we had a £2.9 million grant from EME, NIHR, which is looking at exactly this study to look at, which has already started in UK. Sheffield has already recruited the first patient this week. And we are looking at standard of care chemotherapy. So patients are subtyped, and by genotyping, then we randomize patient between the standard of care chemotherapy, which is gemcitabine and cisplatinum, versus what the subtyping is basically identifying as the best treatment option, which could be IO plus neoadjuvant chemotherapy. It could be no treatment at all, going straight to cystectomy. So again, you're not giving everybody neoadjuvant chemo, but actually there's a group who may not benefit from neoadjuvant chemotherapy, and they should go straight to cystectomy because they will be not benefiting from neoadjuvant chemotherapy. So again, precision medicine helps us to reduce the cost and reduce the toxicity for our patients as well. And again, this is only possible where we have got joint urology, oncology, pathology, multidisciplinary team members working together. So this is myself with Jim Cato, and there we have got quite a few of our surgical colleagues and our multidisciplinary clinical nurse specialists and the clinic nurses. But the joint clinic makes a big difference. Where I'm sitting here, Jim Cato is in the next room, and patients flow between our clinics. That means less time, less delays in patients' treatment, and much better outcomes. So that's how we've contributed to a number of national and international clinical trials. We have set up and started trials where we are leading, and we are getting huge support from national and international sites as well. Key thing is that the current practice today is trial and error. We are moving into the era of personalized medicine with the right treatment for the right person at the right time. And I'm glad to say that we are there now, where we are achieving that. And that has only been possible because of the huge collaborative efforts nationally and internationally. And I think the disparity in treatments that are there, we need to reduce them as well. And I do hope, coming to this amazing event, which has been so well organized and so many exciting talks we have heard here, and having discussions with a lot of very senior colleagues from Shaukat Khanum Cancer Center as well. I do hope that there will be a huge amount of work that will come out from Shaukat Khanum. And you will always find me a very willing partner. If anything I can do to help support Shaukat Khanum and other institutes in Pakistan, I'm always there for that. Thank you very much for your patience, and thank you very much for the invitation for this plenary talk.
Thank you, Professor Hussain. We may have a couple of questions from the audience if we have.
Thank you, Dr. Amir Hussain, for such a nice and extempore lecture. My question is that you told about the intravesical chemotherapy, especially atezolizumab. Well, it will be for the superficial tumors or for the invasive?
It is quite a pragmatic study. It is for muscle invasive bladder cancer or BCG resistant non-muscle invasive bladder cancer. So any patient who is being planned for cystectomy, as we know for muscle invasive bladder cancer, neoadjuvant chemotherapy is standard of care. So if the patient does not receive neoadjuvant because they are cisplatinum ineligible, those patients will also be available for this study. Because the key thing is to look at translationally, when you take the bladder out, how much of the drug actually goes into the lymph nodes as well? Is there any spilling of that drug? So there are a lot of things that will come out from it, but we are not delaying their surgery. So they will have both components, muscle invasive and non-muscle invasive.
Yes, and for the bladder conservation treatment, would you like to have this atezolizumab or gemcitabine plus carboplatin combination?
I think in the organ preservation, you're saying, yeah?
Yeah.
Yeah, in organ preservation treatment, there are trials already going on, which are looking at adjuvant durvalumab. We are doing a trial in UK called Radio, which I'm leading with Nick James. And that trial looks at basically mitomycin C5FU plus durvalumab in combination with radiotherapy. So the new studies are coming, which are adding immune checkpoint inhibitors in organ preservation treatment as well.
Okay, thank you.
Thank you, Dr. Hussain, for such a lovely talk. And we were able to grasp some new concepts. My question here is about that. How do you compare the NGS, the standard NGS, to the ctDNA approach? Do we have any studies regarding that?
I think a lot of these studies are retrospective studies. I think the key thing is that how you can use those prospective trials where you have predefined it. Because when you do retrospective studies, that becomes more like a fishing exercise. But things like IMvigor 011, where the trial has already been designed in that way, where you will be doing these things beforehand, that will hopefully help us whether there's any discordance. You also look at, are they concordant what you're seeing, or there are discordance, which means you can use this or that. So that's where I said, while blood is much easier, ctDNA is much easier. Biopsy may be a bit more difficult to get because it's an invasive procedure, but having randomized trials in the adjuvant setting, you'll be able to get some of those answers.
And I think down the line, we can have more answers that if maybe we can sometimes just rely on ctDNA, and in some cases we can rely on NGS. So we will be more confident maybe down the line over a few years.
I agree completely.
Yeah. Thank you. Thank you very much.
Sir, my question is, there are a lot of treatment options available for urothelial cancers. Are there any ongoing trial for non-urothelial cancer as well?
Yes, there are trials on basically patients with divergent pathology. There is a trial looking at immune checkpoint inhibitors in patients with divergent pathology. There was some data that we were part of that was presented at ESMO 2 weeks ago in Madrid, and that is called a trial called Abacus-2. And Abacus-2 very clearly looked at the use of immune checkpoint inhibitor in patients with divergent pathology. So again, patients in neoadjuvant setting, patients undergoing cystectomy received immune checkpoint inhibitor 2 cycles, and then had cystectomy. So you will see more data coming out. In advanced metastatic setting as well, we are having a study, but these are rare patient population. But again, and that's why they've not been part of many trials. So we do hope that those studies will shed some more light in that.
Thank you, sir. I have one more question. Is there any role of immunotherapy and bladder preservation in neoadjuvant setting concurrent with radiation therapy?
Yes, we are doing that trial of organ preservation. Again, neoadjuvant chemotherapy, we use that. If you remember BC 2001 trial, which we led many years ago, published in New England Journal of Medicine in 2012, that was part of my doctorate, phase 1-2, many years ago. So that trial had neoadjuvant component as well. We published that in European Urology 3 years ago, and 118 patients out the 360 patients received neoadjuvant chemotherapy, and those patients did not compromise on radical chemoradiotherapy treatment. So neoadjuvant chemotherapy does not compromise the delivery of radical radiotherapy treatment, radical chemo-RT. So we do recommend patients should have neoadjuvant chemotherapy because that will lead to improved survival 5-6% down the line. And in terms of the immune checkpoint inhibitors, as I mentioned, the radio trial we are running in UK, there's a couple of trials in America that are going on as well that are adding on immune checkpoint inhibitor concurrent with radiotherapy. And then following on, they have further adjuvant immune checkpoint inhibitor as part of that treatment as well.
Wonderful. I think that's us from the questions perspective. Thank you very much, Professor Hussain, for this lovely talk. Thank you, Dr. Asim, for joining us virtually, and everyone who has joined us in person or virtually. Thank you all.
Sorry, I have a question, if you don't mind. My name is Irfan. I'm a consultant neurosurgeon working at Shaukat Khanum. And, you mentioned about getting liquid biopsies and getting DNAs and fragments of RNA in the blood. What is your experience in getting similar samples for brain tumors? Because of the blood-brain barrier, especially for low-grade gliomas, I don't know whether fragments would come through in the blood, but high-grade gliomas and other metastases tend to break that barrier.
I think that's a great question. I agree with you completely. But I think where brain tumors can actually provide you more opportunities within this challenging scenario is that the primary thing you take out is the brain tumor. So you actually have the real sample sitting in there. So I think in brain tumor, we are doing some studies, evident platform that I showed you. In that, we have got some brain tumor cases as well. We've done mainly bladder cancer and kidney cancers, but a lot of brain tumor because exactly for the same reason, because the blood may not tell you everything. And that is where but you have got a tumor sample. Any patient who presents with a mass in the brain with a question mark, is it brain mets or brain primary, you will usually take it out. So you will have those samples. And I think that's where I'm saying that in terms of, your strengths, you know where you've got huge number of patients, you know where you've got a surgical colleague who's really keen to work with you guys and get some more answers. And that is what can throw in. There could be some of these which will be very challenging for some other centers or other parts of the world, could be a huge area of strength for Shaukat Khanum. So, but yes, I agree with you. But when you do those brain samples, you can look at the ctDNA and in the blood samples as well. But you might find that there may not be that much concordance.
Thank you.
Thank you. So many things to learn from Professor Hussain. Thank you very much. I'm not sure if we have Dr. Asim with us, who might want to say a couple of words. Dr. Asim, can you hear us?